weekdays at 3 on Local 3.
We have reached the point where when you know somebody who's having a hip or a knee replacement, it's almost kind of commonplace, unless I guess you are the patient. So if that's something that you are facing, listen up. Dr. Josh Lawson is back on the show with us with the Center for Sports Medicine, and his specialty of sorts is robotic assisted surgery or joint replacement. So good to see you.
Good morning, thanks for having me.
So you and I were chatting a little bit off camera. I'm going to tell a tale on you.
Yeah,
is that
ahead.
okay?
Absolutely.
I had asked him if it was awkward as a surgeon to kind of learn to rely on the AI technology. It really wasn't for you, but you were very much at the forefront. The doctor who you served under during your fellowship consulted to create this very procedure. Did I get that right?
That's correct. Yes, ma'am. So my fellowship director in Louisville, Kentucky was on the consultant team for Stryker, who came out with the Mako surgical robot. And he was one of the designers, so I was able to learn directly under him. And it was a big step learning to trust that sort of equipment and technology early on, because you train for so many years doing it kind of with your hands, with your eyes, and so learning to trust the technology, that it is as accurate as they say and precise as what they say. It does take a little bit of time. It was great being able to train under him, so you have that confidence that you are doing it correctly. I could see where it'd be pretty nerve-wracking for an experienced surgeon to try to pick that up and learn to trust it, and because it is a very different way of thinking through a knee replacement compared to traditional approaches. And so it was great being able to learn and train in my fellowship year when that device was fully released to get kind of a head start in that technology and bring it back to Chattanooga.
So are you utilizing it in knees more than hips, or is it for both?
I use it more in knees than hips. So my technique for hip replacements, the robot was really designed for a different approach to get into the hip. So it adds a little bit it's just more of a cumbersome approach to do. What I do is an anterior hip replacement. So it's more designed for a posterior approach surgeon. So some of the placement of some of the components for the robot, it's a little out of sorts for an anterior approach, and I'm able to use X-ray rather than the robot. So it's just a little more streamlined approach in the way I do it. But I have seen a big improvement on the knee side with regard to patient satisfaction, how quickly they progress through physical therapy, and how satisfied they are with their final result.
I want to get into some specifics of that, but I want to have kind of a terminology emphasis for a minute, because most of us lay people will say, oh, it's robotic surgery. You can't leave out the word assisted.
Correct, yes. So it is not a device that is replacing your surgeon in any way. It is simply a tool we are using to get more accurate information on the knee side regarding limb alignment, range of motion, and most importantly, ligament stability. And we're able to make just more fine-tuned decisions and fine-tuned placement on where that knee replacement actually sits in a patient's knee to maximize those variables and those factors, which we know affect outcomes.
Okay, I'm in no way a surgeon, but I'll let my knee be the prop.
Sure.
Okay, so suppose it was my knee, and you have my knee and my husband's knee. If my individual problem just happens to be, 10 degrees this way, and Mark's is 15 degrees this way, that makes a big difference. Is that where the robotic part comes in?
Correct, yeah. So instead of maybe trying to make up for some of that difference in soft tissue balancing, which is not very accurate, and it's very subjective patient to patient, we're able to actually make very finite changes through the bone preparation to maximize and optimize where those components sit, and then therefore actually measure to make sure we're recorrecting that alignment to as straight or as neutral as we can get it.
So is there ever somebody who comes into your office who needs knee replacement who would not be a candidate for the robotic assisted?
No, so if you're a candidate for a primary, either partial or total knee replacement, you would be a candidate for robotic assistance. The only we can't use robotics for revision surgeries. You can kind of use it off-label in certain situations, but it's not indicated for that. But yes, if you're a candidate for a partial or total primary knee replacement, you'd be a candidate for robotics.
I mean, I think probably you could put 10 people in a room and they would all have stories to tell, good and maybe not so good, of people who've had knee replacement surgery. So is this kind of improving the outcome?
Absolutely. So historically, with the manual approach and techniques, about 80% of people would be satisfied with the function of their knee, how it felt through their day-to-day activities. With robotics, we've got that more in the 90 to 95% range.
That's big.
It's a big jump.
That's that 10 to 15% that we were just talking about,
Absolutely.
right? What about the prep? If you've ever had surgery, often the pre-surgical part is as involved as the day of surgery. So are you doing some of this measuring before they ever get to the OR?
Correct, yes. So with the Mako robot in particular, we do get a CT scan preoperatively, and so we can plan a lot of the component positioning even before the patient ever gets into the operating room. So we know pretty good idea of what size component we need, kind of what alignment component, or where we will align those components. There's another device came out a few years after. It does not require CT scan, so we get those same measurements during the surgery, at just a minute or so to get the same calibrations, and then we do that planning during the surgery.
You mentioned earlier, if you are a candidate for the surgery, then you can do the AI assisted or the robotic assisted. It's hard when your knee hurts and you're not the candidate.
Correct.
What do you do in those situations?
Yeah, so there are lots of non-operative things we can try, such as oral anti-inflammatories. Physical therapy can be very beneficial. Cortisone injections are very common, as well as what we kind of term gel injections or hyaluronic acid injections into the knee. That can also be an option. And all those are typically fall under patients' insurance approval plans. There are some additional things you can try, like PRP. Those typically don't fall under insurance approval, though.
If you're a minute left, if you're reaching the point in your life where you're hearing some cracks in there, I'm hitting that point, is that kind of a warning sign that you better get some preemptive?
That can be an early indication that at least the cartilage is starting to kind of crack and fissure and kind of break down a little bit. And so certainly want to maybe assess some lifestyle choices, how active you are, things like that, just to delay the progression of that arthritis and maximize quality of life, with hopefully so you don't have to see me in the office.
All right, but if you do want to see him in the office, here's where you'll find him. It's the Center for Sports Medicine, and you know they have locations all around the viewing area. So if you just go to sportmed.com, you can see the one closest to you. There's their phone number if you want to call and make an appointment. Dr. Josh Lawson, he's the one to ask for.
Thanks so much.
With McValue at McDonald's, you'll get deals on breakfast, which comes in